And what do we begin with? We're going to begin with just generalized inspection. So obviously we're going to have access to the skin. And so you're going to inspect the abdomen. We're going to look for symmetry. Both sides are equal, even. We're going to look for any scars, any lesions. We're going to look at her umbilicus to see if it's outy, any mass underneath that, if it's normal. You want to observe for any pulsations. So if she's resting, she's comfortable, you'll see a light pulsation, but you shouldn't see any masses protruding. She should be laying down all the way for the exam. And then to test for a hernia or a bulge, what you would have them do is come up to 30 degrees, and put their head down. So just pretend you're going to put your chin down to your chest. So coming up, flexing 30 degrees, head down is going to put tension on the abdominal area. And if she had any sort of hernia, it would like sort of pop up. So we would see a hernia. So looking for hernias or bulges. So inspect the skin, inspect the umbilicus, inspect for hernias, bulges, have the patient lift up and put their head down. And then you begin with auscultation. So you're going to get your stethoscope and you're going to listen to right upper. Can you guys see okay?
Yeah.
Left upper, left lower, right lower. You want to listen for at least, you verbalize this, we listen for 2 to 5 minutes, but you want to demonstrate during the exam that you're going to listen to all 4 quadrants. And then on part of the abdominal exam, as we said, they want you to listen to the arteries as well. So after you listen to all 4 quadrants with your bell, you want to listen to the aortic arteries. So you want to start at the aorta. And then you want to do the renal arteries, and we're going to put our diaphragm. And then you're going to go to the splenics, which are right off the renals. And then the iliac, which are in the femoral. So you want to listen to all of those arteries, 30 seconds to 1 minute. You're listening for bruits or thrills, the same that we would listen for here. Once you listen to them with your diaphragm, you want to flip over and listen with your bell as well for any of those high-pitched sounds. Okay, so auscultate the bruits. Then we start with percussion. So percussion, again, is the tapping. You guys practice what you're comfortable with. It could be tapping on 1 finger, tapping on 2 fingers, whatever. When you're percussing, you basically do all 4 quadrants. And you sort of just go around the belly in general in that area. You're just looking for tympany, you're looking for air, you're looking for gas in this area. We're not really percussing organs, we're getting deep into that. So just a general percussion, looking for anything specific that you would find right away.
I'm not really sure what percussion helps to really assess what I'm.
It's the sound. So what should it be typically?
Yeah.
So when you're percussing, for the most part, you're just going to get just a regular dull sound. There's organs in there, so think about percussing a cup, an empty cup, right? You're going to get more of you're going to get a tympanic sort of air-like sound back at you. If you're tapping onto a hard surface, you're not going to get really anything back. It's just a flat sound. Air is going to be tympanic. So practice on items at home so you know what you're listening for. In general, percussion only works if you have gas or air or fluid. So those are the 3 times that percussion is going to give you any message. Okay? Otherwise, if you're percussing a regular flat abdomen, you're not going to really pick anything up. We're really doing it when we have ascites, when you have bloating, when you have gas, when you have anything that's going to cause that reproduction of sound. So percuss the abdomen, and then you're going to do the palpation. So the first palpation is what we call light palpation. So you just lightly go over right upper, left lower, right lower, and you're just palpating the patient's abdomen. And then you want to do deep palpation. So deep palpation involves a little bit more depth. And as you're palpating, you would ask your patient, does this cause you any pain? And you're just doing a general. We're looking for masses, anything protruding, anything tender, anything out of the norm. Is she going to say ouch anywhere? These are not your special signs. This is just generally what's that feeling under there. Is it hard? Is she guarding? Is there any resistance? Is it normal? Is it soft? And where is she tender? So points of tenderness. Okay, is she tender here when we do that? Tender up here, tender here. So general palpation first.
So do you start from the right upper quad and go?
I always do, and you're on the right side of the patient when you're assessing them, typically. And so, start with the side that's closest, and then clockwise. Then we have special signs. So these special signs are specific to, we think she has gallbladder, something going on. So Murphy's sign is testing right upper quadrant pain, right under the rib cage. So we want to find the rib cage, and then usually you just want to push. It says you can do like a hook-like. So here's the rib cage. You can do hook-like pain and push up into the gallbladder. I usually stand this way to a patient, and then I will palpate. I'll find the rib cage and just go in and up a little bit, and it hurts. And imagine if that was tender, it would really hurt. So in and up towards the gallbladder. So pushing in. So I just tell them, take a big breath and let it out. Does that bother you? Right. So that helps for me, taking a big breath, letting it out. It distracts them, and it's not as bad as you pushing them while they're breathing out or breathing in or whatever they're doing. So this is called Murphy's sign, tending for right upper quadrant tenderness. A positive Murphy sign would be like, ouch, it hurts. Then you do McBurney's point. McBurney's point is located a third of the way between the umbilicus and the iliac crest. So if you really want to measure it out, we get the hip bone, the iliac crest, and and here, and it's typically a third of the way there. So her McBurney's point is right here. So McBurney's point just means we push down on that area, and any pain there. So that would be for appendicitis, any tenderness in a McBurney's point. Then we do obturator and psoas. So psoas is basically, I'm going to put my hand on your thigh, and what I want you to do is I want you to lift up. Does that cause you any pain?
No.
Does that hurt anywhere? No. Okay. And sometimes you say, does it hurt here? Does it hurt anywhere? I wait for the patient to tell me, because when you tell them, if it hurts somewhere, they'll tell you, yes, it does. So I say, does it hurt anywhere? That's my way of doing it, because I don't want them to know what I'm looking for. Because if they do, then they're a little bit more sensitive. Oh yeah, it hurts right there really bad. So that's psoas, is just hand on the thigh and have them lift against resistance. So it should hurt here if they have appendicitis. Obturator, lifting up. Internal rotation. Internal means towards the body. So bend at your knee. Bend at your knee. Oh, sorry. And then turning it a little bit, and it should cause a little bit of friction here on this obturator muscle. Again, might cause some tenderness in the appendix area. So psoas, obturator sign.
It's just putting pressure over the area.
Just the same area. And then rebound tenderness. Rebound means it doesn't hurt to push in. It hurts when you release, right? So looking for rebound tenderness. You push in, you say, does that cause any pain?
Yes.
Yes?
No. Now
If I let go?
Yes, now it does. It's rebounding.
And does that cause any pain?
No.
And if I let go,
Yes.
does that cause any pain? So rebound means you're just jiggling that area. So rebound tenderness is a sign of peritonitis or appendicitis. So appendix, an inflamed organ will inflame the wall, or peritonitis. So if they're having rebound, it just means when you release, everything moves and that wall hurts, okay? So rebound tenderness, and then sit up for me, Laura, put your feet down and turn around. We'll go turn around this way, sideways, a little bit more. Perfect. So CVA tenderness, the last thing in part of the abdominal exam because of the kidneys. So you look for your posterior costovertebral angle, so where the end of the rib cage basically. Think about where your kidneys would be, right? They're right back here, okay? And then all you do is you tap on them, okay? Is that tender? Does that hurt? If they have pyelo, if they have a UTI, if they have glomerulonephritis, if they have any kind of sensitivity to the kidneys, that will hurt. This will hurt them really bad. Or if they have stones. Some people use their hand and tap on it so it's not direct, hand and tap on it, or turn around that way so we'll show them. Or you just find that angle, you tap on it directly, or hand and tap on it that way. And that causes that vibration that should make it hurt. Okay? So that's your abdominal exam. Okay? Yeah, that's pretty much it.
That's what you would like for our final.
Yes, so that's what you're gonna do when you, if you get that system. Now let's do the vascular one as well while you're here. Yes.
With adults, I know with kids, if they have like, if they have caloric stenosis or lung tumor, you don't wanna pump it.
Yeah.
And if those are there any masses that you shouldn't.
Well, and that's why we auscultate first, because if you have, you don't wanna touch, you don't wanna palpate masses. So yes, we're palpating, but if there's a protruding mass, if there's any kind of bulge, you do not wanna palpate any further. That person does not get the full abdominal exam. If there's a mass you don't know, if it's an obstruction, if it's torsion, if it's, it could just be a tumor, it could be a hematoma. We don't want anything to explode, and we don't want anything,
No exploding
literally,
masses.
no exploding masses. So yes, if there is a mass, you don't palpate further. Usually, if it's something like a cyst or something in the skin, yes, you can proceed. But if it's anything internal, you stop right there. That's your abdominal exam. There's a mass, and they go on. Okay, the peripheral vascular system. So this is our arteries, veins, and skin. So overall assessment. Okay, how does her skin look? We want to look at the overall color. We're looking for pink tone, blue tone. We're looking at the lips. We're going to look for any cyanosis. We're going to look for any varicosities, so varicose veins, bulging veins, arteries, spider angiomas. Think of everything that's artery vein related. Any dilated veins. And then you palpate the skin turgor. You guys know this, the tenting. So we could do skin turgor on hands, and you do skin turgor on feet. So we're looking for tenting, signs of dehydration. And then you do the pulses. So you're going to palpate the pulses. So carotid pulses, you're going to use the bell of your stethoscope, and we're going to listen to carotid on each side, one at a time. So you guys know the rule, we don't hold the carotid
Down she goes.
down, yeah. So one at a time, carotids. And then you are going to do the brachial. So find the brachial pulse. And again, you want to listen to the pulse, feel the pulse for a minute. And you want to do this bilaterally. So the person who's doing, whoever gets peripheral vascular, you want to check pulses bilaterally. And you can do this. And then you want to do radial. Ulnar pulses. And then we do femoral pulses, so you want to get into the femoral artery here bilaterally, check femoral pulses. Popliteal pulse, so bend, relax it. So the best way, just have them relax. You kind of scoop your hand up like you're going to grab something, and you bring it behind the knee. And then you just want to put the tips of your fingers right behind that medial aspect of the knee. And you go pretty deep to get the popliteal pulse. It's not just right there. Push in until you find it. And then you want to check that popliteal pulse on both. Relax. And then dorsalis pedis, right on the surface of the feet. And posterior tibialis, this is called your medial malleolus. So your posterior tibialis is right here. So dorsalis, posterior. So again, as part of the peripheral vascular, look for edema. So while I'm down here, I'm going to check for edema. What else is on here? Edema and cap refill. So you guys know this, less than 2 seconds, fill time, cap refill. And the last thing on the peripheral vascular exam is Hohenheim. So Hohenheim is looking for DVT. So we'll pretend she's laying down. I think the book shows 2 ways. The easiest way to look for Hohenheim is to flex just a little bit at the knee and have them point their toe towards them. And this should cause that tightening, that extension of this muscle should cause a pain here. if they have a DVT. Same thing, yeah, on both sides. So flex a little bit and have them push up. A lot of people just have you, I don't know if you can feel it, just relax all the way and then push up. Yeah, that doesn't stretch it as much. Some people just push, like in the hospitals I've seen, they'll just push against the feet, testing for Homans, but have them flex a little bit and then push up, and then you do that. You can also do Homans if they're laying on their stomach, and you bring their knee up, and then you flex this way. So you extend the foot if they're laying on their stomach. And that's pretty much it. Those are the 2 exams, so abdomen, peripheral vascular. Questions? No? Good? Okay, I'm gonna run down the entire system real quick. So, in terms of, you know, when you have your patient, we'll pretend, stay right here for me, Ron.
You are the star.
Well,
I'm still on.
this is our patient, you're doing your presentation, we've identified our patient, she's our 54-year-old female, she came in today with chest pain. She's coming in with chest pain, you're gonna give us your scenario, we'll pretend, I'm gonna do the whole thing, but you're gonna go on to say, we'll take her vital signs, you want to measure height and weight, tell us what it is, her blood pressure, temperature, pulse, respiratory rate, blood pressure, pulse ox, assess for pain. Okay, I'm gonna begin with the entire exam. So, the first thing, whoever has head, HENT, inspect the skin of the face, the hair, the distribution, the shape of her head and the size, and you want to palpate around the skull. We're looking for any masses or bulges. At the same time, you want to look at the hair distribution. What are we looking for? Alopecia, bald spots, dandruff, folliculitis, sebderm. We're looking for lack of good quantity hair, the color, examining that. We want to look at the facial features. We're looking for asymmetry of the face. We're going to palpate for sinuses. So I would do this from the front, but because you guys are recording. So frontal sinuses, we would push down, and you would use your thumbs if you're in the front. And then maxillary sinuses, push down. Any pressure? Does that pressure cause pain?
No.
No, good. So do your sinuses, and then we do the lymph nodes. So again, we start with the occipital lymph nodes, which are here, back up here in the occipital. We do palpate for pre-auricular lymph nodes, post-auricular lymph nodes, tonsillar lymph nodes, mandibular lymph nodes, submental, submental lymph nodes, and then you have your anterior cervical chain, posterior cervical chain, supraclavicular lymph nodes. So palpate for all the lymph nodes. And then we move on to the eye exam. So the first thing you want to do is inspect the eyes. Again, we're looking for size and shape, bulging. Look at the skin, the eyebrows, the hair distribution, the eyelashes. We're looking for redness, we're looking for horculums, we're looking for styes, we're looking for discharge in the eyes, redness, signs of conjunctivitis. And then you're going to do corneal reflection. So what that would mean is, I'm going to have you look up at that light, Laura. Corneal reflection, you can take a light, shine a light, and have them look up at that light, or look up at any ceiling light. You're looking for that reflection centered in the pupils, equal in both eyes. And that just tells us about deviation, pupillary deviation, and response. Then you take your pen light and look straight for me. We're going to do Perla. So pupils equal, round and light, round and reactive to light. So check each of the pupils, check the response to light. And then accommodation. So I want you to look here at my pen light and follow it with your eyes. And accommodation just means that her eyes, her muscles are intact and that they move symmetrically. So Perla, and then extraocular movements. You take the same pen light, and I want you to follow this with your eyes, and you're going to check the 6 cardinal gazes. So you could do lateral, H, or you can do an X, and then I usually do an I in the middle of the X. So check the extraocular movements, and then you want to do your peripheral vision test. Peripheral vision test can be done from the back. You're going to look straight ahead for me, Laura, and you're going to tell me when you see my hands in your vision, okay? When you can first see them. So peripheral vision is testing to see that they have vision at 90 degrees. Tell me when you see them. Yes. So it should be equal. So if something like this were to happen, she never saw this one, then we know that she's lost her peripheral vision in this eye. If you're doing it from the front, then you bring your hands back here and you tell me when you can see my hands. Look straight at me. Yes. Okay, so that's the eyes. And then the ears. So look at the ears, inspect the pinna, the outside of the ear, and we're looking for any lesions, any signs of skin cancer, any redness, any discharge from the canal. You can pull up on it, check for tenderness, push down on the tragus, checking for tragal tenderness. And then you want to take your otoscope and look inside the ear. And we're going to be looking at the external canal, the internal canal, the tympanic membrane. You want to see shiny, pink, pearly, gray, reflexive light. No discharge in there, no exudates in there. And then you want to test for hearing. So the two tests we do for hearing, one can be the finger test or the whisper test. So finger rub, plug one ear. Tell me if you can hear this.
Yes.
And then you plug the other ear. Can you hear this?
Yes.
So that's a finger rub. If you do the whisper test, you want to stand at least about 2 feet behind the patient. Plug this ear for me, Laura. And tell me what I say. And you want to use 3 digits.
5, 1, 2.
Plug your other ear.
3, 7, 5.
Okay, so that's the whisper test. And then we'll do Weber and Renee. So you'll have a tuning fork. And in order to do Weber, you vibrate your tuning fork. You cause a vibration. We're going to put it up here. And then with the vibration, you should be able to hear it in both ears. Laura, do you hear that in both ears?
Yes.
Does the sound equal?
Yes.
Okay, good. So that's Weber, just a positive without lateralization. Renee, we cause it to vibrate, and we're going to put it back here on the mastoid. Can you feel that, Laura, the vibration? Tell me when it stops.
Stop.
And then if I put it here in front of her ear, the top of the tuning fork, she should still hear it. So air conduction should be greater than bone conduction. So tuning fork, back on the mastoid process. When she stops hearing it, it comes to the front. She should still hear the vibration. Okay. Then we do quick nose. So inspect the nose. We're looking at the outside. We're looking at the septum. We're looking for deviation, any discharge coming from the nose. Have the patient look up. Take your pen light, look inside each of the nares. We're looking for any redness, mucosa, the drainage, polyps, and then you want to test their sense of smell. So alcohol wipe, whatever you have. Close your eyes for me, Laura. Plug one of your nostrils. And can you smell this?
Yes.
What does it smell like?
Alcohol.
Okay, plug the other nostril, and then we'll put the alcohol. What does that smell like?
Alcohol.
Okay, just a sense of smell. So throat and mouth. Look at the patient's lips. Start with an inspection, okay? So look at the lips. We're looking at color, cracking, lesions. We're looking for herpes. We're looking for signs of AIDS, candida. Look around the edges. Go ahead and open your mouth for me. Say ah and stick out your tongue. You use your tongue depressor to create a gag reflex. We're checking for vagus nerve. We're going to also, with the pen light, look inside the mouth. You want to look at the roof, the pharynx, the posterior, the teeth, the gums, the tongue. You want to look at the shape and the condition of everything inside the mouth. We're looking for lesions. We're going to look at the tonsils. Look for enlargement. Look for exudate. Look at the tongue, shape, size, color. When you stick out your tongue all the way, you're looking for deviation. So is it hanging to one side? Is it hanging to the other? Does it come straight in the middle? We talked about facial symmetry. When we look at facial symmetry, have your patient smile. Smile for me. Frown. Wrinkle your forehead. Puff your cheeks for me, Laura. Puff, puff, puff. Stick your tongue out here. And stick your tongue out into your cheeks. And I'm going to push against it, okay? So testing tongue strength and testing facial symmetry. When she smiles, when she frowns, all of the face, everything responds equally. That's that. And then neck, so head to toe. So neck, inspect the neck, look at the skin, look at the trachea, look up for me. Look for trachea midline, no deviation of the trachea. We're going to palpate for the thyroid, so again, under your cricoid process, come from the back of the patient, swallow for me, Laura. Palpating the thyroid gland, which lays right around here. You're looking for masses or bulges. We looked at the trachea, we're making sure there's no deviation, and then we're gonna check the strength of the sternocleidomastoid muscles, so these muscles here. So I'm gonna push down, Laura, and I want you to push up against resistance. So checking the strength. Sternocleidomastoid muscles and the trapezius muscles. Thyroid, trachea. And then we did heart and lungs. So for the lung exam, inspect the chest, front, back, the skin of the chest, looking for any lesions, any scarring. Look at the shape of the chest, convex, concave, barrel-chested. AP diameter means anterior, posterior. Stand on the side of the patient and look at the size and the shape of the chest. Inspect all of that, and then the first thing we're going to do with the chest is palpate for fremitus. So have you turn around? Just go much this way. So palpating for fremitus, again, use the palms of your hands. Say 99 for me, Laura. 99. 99. 99. So we're palpating for fremitus, which means we're looking for masses, liquid, dullness. If it comes out clear 99, if you could hear the 99 or feel the 99 clearly, then there's a mass. If there's not, otherwise it will not be clear. Palpate, percuss the lungs all the way down, percussion, and then we're gonna auscultate. So listen with your stethoscope. 1, 2, 3, 4, 5, 6, 7, and 8 right middle, and then turn around, and then you want to listen to the 2 anterior at the apices. So listen to your lungs up here. So percuss, and then also on the lung exam, they want you to inspect the spinal column. So when we're doing this lung and you're inspecting, then you want to observe for any deviation of the spine, abnormal curvature, scoliosis, kyphosis, lordosis of the spine. So that is the lungs. And then heart exam. So you turn around. Heart exam, inspect the chest. Look for any heaves, lifts, bruits, thrills, any palpations, anything abnormal going on there. Palpate the chest wall. So palms of my hand, I use palms of hands. Just lay them over aortic, pulmonic, aortic, pulmonic, tricuspid, mitral, and you want to palpate the areas of the chest. You're looking for lifts, heaves, anything, murmurs, kind of regurgitation kind of sounds. We don't percuss on the chest, and then you want to listen for heart sounds and carotid bruits. So you take the diaphragm, aortic, pulmonic, Erb's point, tricuspid, mitral, and then you want to listen to the carotid with your bell. And then you want to palpate the point of maximal impulse. So again, 5th, intercostal space, mid-clavicular line. And then, of course, the patient should be laying down for this exam. And we'll do a make-do bed. We'll do a make-do bed with sheets and pillows. And then you palpate the point of maximal impulse or your apical pulse. And that's it. And then vascular abdomen. Next week, we will do neuromuscular, and then that covers the entire systems. Questions? With that,